Valerie Rossiter, Chair of Parkinson's UK and Ferren Gosport. Maggie, can I take you back to the question of prevention? Obviously, this is a huge thing as far as Parkinson's is concerned, that we know that it's a degenerative illness, and as it degenerates, so it brings increases in falls and other add-ons and other costs to the health service. We are therefore, as a local organisation, and I represent 400 members, more than a little concerned about the cutbacks in clinic provision at the War Memorial Hospital. People who have habitually been seeing their specialists 6 monthly are now down to 8 to 10 months. People who have been given yearly appointments are having them pushed on to 15 months. In the terms of the increase of the problems of Parkinson's, 15 months is a heck of a time, by which time they go into hospital. Parky people don't go into hospital normally. The Parkinson's as such doesn't put people in hospital. The side effects do. And the cost of the health service is going to be considerable if we have unaccountable footfalls because they're not being monitored properly. Also, of course, we have huge problems with the drug regimes, which often need cutting back, not increasing. And if nobody is checking on those, it really is a problem. And thus far, my patients on the whole don't bother their GPs unnecessarily because they know that they're seeing a specialist who will really know their illness. Is there any reason why these clinics have been cut back?
Well, thank you for sharing that. That's really important to know that. I'm going to look to colleagues because I don't know, I haven't been briefed about that, so I don't know if that is happening or does anybody? I'm sure.
I think it's a reflection of all of those issues we have within the health service. That there's increasing demands, greater number of people, and not a corresponding increase in the number of specialists. And I think that's why we have to sort of say going forward that actually doing more of the same isn't really an option. So as quickly as the population of people with Parkinson's is increasing, we won't increase the number of sort of specialists. So we've got to look at differing ways of providing that care.
So is there a way of monitoring what effect that's having on those patients?
So I think with things, I mean, it's going to be about that sort of relationship. So you know, how are we, you know, as you say, patients may not want to bother their GP, but of course they are having their prescriptions provided by the GP, you know, and how do we join things together? What you're describing there is the classic NHS disjointed bit there of a specialist here and then somebody providing some of the care there, and them not really communicating with each other and with you as either the carer or the person with the condition. And I think that's really a lot of the ethos, I think, behind the new model of care approach there is to say that, you know, unfortunately, looking at the rise of things there, we won't keep pace in terms of doing what we've always done. So how do we transform and change how we do things there so that actually, you know, in a sustainable way, we can then, you know, deliver the care in a different way that is still of high quality and is still safe, because as you say, as David sort of alluded to there, actually, you know, the costs of that fall, that unplanned period of time in hospital is actually not what we want to see happening there. It's not in commissioning groups' interest for that to happen. It's not in patients' interest for that to happen there. But it is with the current model, and so that's why we're so keen to sort of to provide a different model. Alex,
I wonder, perhaps I could catch up with you and just have a conversation and then look into some of the details a little bit more and then come back to you about what actually is happening and some of the issues that you're raising. I don't know the details to hand now, but perhaps I could pick up afterwards.
And the other thing I was going to say was, when it comes to monitoring some of these services, I'm only one of many big voluntary organisations out there, and whatever we can do to support CCG in terms of collecting data, then for heaven's sake, let us know. You know, once a month I have 90 people with Parkinson's or living with Parkinson's at a coffee morning. You know, it's a lot quicker to get round my people sometimes than trying to do it through the surgeries.
my dad had Parkinson's disease, so I kind of can appreciate what people go through and what carers go through as well. So I think one of the important things is how we can work with a group like yours, because you have the intelligence and you are talking to people and you know the individuals, and under this new way of working that's being described, we would expect you may not get as much access to a hospital consultant specialist, but there may be more access, and there should be more access, to a specialist nurse or a team of people that are working with the GPs and yourselves to ensure that when people have got an issue, or we think someone's getting a bit wobbly on their feet, or they've had a couple of, kind of trips, then we're alerted to that, and some intervention is put in place. And that's about working much more intelligently with the monitoring and the use of data to make sure that when people need it, it's there, rather than them getting taken in an ambulance to hospital. And so working with you is what we would really want to do going forward.
Yeah, that's right. It's something actually that I've done for years on an ad hoc basis. Chris Gorman will tell you that she often comes in the morning, our Parkinson's nurse, and finds a message left by me at 3 o'clock in the morning.
I'm sure she does.
But it works, because I can say, saw somebody yesterday, looks as if the drugs are in a mess, when did you last see them? That kind of working together, I think, between the voluntary organisations and the CCG could hopefully cut your time and costs.